Hello, I'm Ileana Piña, I'm professor of medicine at Thomas Jefferson University, and I am here in beautiful Chicago at the American Heart Association meetings, and I have with me here a special guest, Dr. Alex Sandhu, who is coming from the Palo Alto VA. I have a very soft spot in my heart for the veterans. And tell me a little bit about what you do. You're a heart failure person like I am.
Yes, I'm a heart failure cardiologist and health services researcher, both at the Palo Alto VA and at Stanford School of Medicine.
And you work with my good friend, Paul Heinrich.
Worked very closely with Paul Heinrich. He was the senior PI of the project we're going to be talking about.
So tell me the name of your project. So for the audience, this project was presented at the American Heart Association.
The project was PHARM-HF, Audit and Feedback. It was a randomized quality improvement study around trying to improve the use of pharmacist care for heart failure.
Why do you want pharmacists in a clinic? Where does this come from?
Well, as you know, we have over 6 million Americans with heart failure, and that number continues to grow. I think we're really fortunate that we live in a time where we have incredibly effective medical therapies for reducing the morbidity and mortality of heart failure. But unfortunately, our patients aren't getting those therapies for many reasons. And I think even when they get them, they're not titrated up to the target doses that we know work. And I think we just need multi-pronged, multiple strategies for how we can really solve those gaps universally across our healthcare systems.
So what's that your thinking behind this study?
That's our thinking behind kind of many of our research projects. And one thing that Paul, myself, and the VA is really passionate about is the opportunity of expanding the care team for chronic disease management and for heart failure. And I think pharmacists, we have a lot of data about their experience with managing hypertension, diabetes.
You do a great job.
We now have randomized data about the fact that when pharmacists manage heart failure, patients are more likely to be on beta blockers, RAS inhibitors, and have them up titrated. So what this project was really about is we now have the data, how can we implement it on a broader scale?
So this is really a translational study. You know what can work. Now you're going to see if you can apply it.
Exactly. When we look at VA data, we see that veterans that are cared for by a pharmacist in terms of their heart failure on higher rates of GDMT, but we also see that only 10% of veterans with heart failure have heart failure care from a pharmacist. So that was the real premise here as to how can we get more pharmacists actively managing heart failure across the system.
You think it's an access issue at the VA, that they don't get sent to a pharmacist, or that the pharmacists aren't embedded in the care? What do you think that difference is?
Well, I think that's actually a really lucky feature of the VA, that the pharmacists are really closely embedded in primary care practices, working side by side with a primary care clinician. And they have a lot of experience with successfully managing diabetes and high blood pressure. Why that hasn't translated to heart failure yet is, I think, really what we're trying to understand. I think a lot of it has to do with there's been less pharmacist training around heart failure management in the primary care setting. I think there's also a bit less focus on heart failure compared with hypertension and diabetes.
The #1 readmission diagnosis in the United States. So break down your study for us.
In our study, we took all pharmacists across our region, across the 8 different sites in our region, and we took any pharmacist in primary care where the leadership said it would be appropriate for them to manage heart failure. This didn't mean that they were actively doing any heart failure management. This didn't mean that they necessarily had any training in heart failure management.
But the primary care bought into it.
But the primary care system was kind of agreeing with them doing that. And we randomized them to one of 3 different arms. In the first arm, we provided education.
Was it education to them or education from them to the patients?
It was education from us to the pharmacist community to try to increase their comfort with heart failure management. It included monthly 1-hour webinars where we talked about GDMT in challenging cases. We built a website that included titration protocols, best practice documents in collaboration with pharmacy leadership. And then we actually built a database of all the questions they asked over the period of time.
That's interesting.
That would be a living resource that when a question came up, maybe someone else has asked it and they could reference that.
Yeah, so if a new pharmacist comes in, they would have something to go back to and take a look. That's a great idea.
So that was the education intervention that was actually delivered to all 3 arms. We compared that with the other 2 arms that received an audit and feedback intervention, where in addition to the education, we provided them a monthly email telling them how often they had provided heart failure care in the prior 3 months and how that compared with their peers.
Did you just capture that on the electronic record?
Yeah, we're really fortunate again with the quality of the data that we have in the VA system, where the pharmacists really closely document each encounter and what care they deliver that encounter. So we were using their own kind of documented care and then analyzing it and providing it back to them, as well as that comparison with their peers.
It's like a feedback loop.
Exactly, and
Very
that feedback
important.
also included kind of what the end goal is, which is to get patients on GDMT.
Right.
We didn't provide them their personal GDMT rates, but we provided it at the site level and a comparison to other sites in the region.
Okay. So they could see where they sat. And that was your group 2?
That was group 2.
Okay.
And then group 3 got the audit and feedback, the education, as well as these targeted patient reports.
Oh, okay.
The targeted patient reports were a list of up to 7 patients in their primary care panel who had heart failure and had gaps in their medical therapy. The hope with the targeted patient reports is we would also help them identify additional patients that they might not actively be seeing, that they could potentially take a population health management strategy, bring them into their clinic and adjust their treatments.
Exactly. So what you find, and how long was your time period?
We followed after the intervention for 6 months. We included a 2-month blanking period, assuming there'd be some amount of time necessary for the intervention to have effect. And then we analyzed from 3 to 6 months post-intervention. What we found is that in all 3 arms, there was an increase in the frequency with which pharmacists were providing heart failure care and doing medication management.
And these are face-to-face encounters with the patients, or are they telehealth? Or?
A combination, predominantly virtual, either via telephone or video care.
Okay.
We saw that between the 2 audit and feedback arms, the audit and feedback with or without patient reports compared with education only, there was also a significant increase in the number of encounters. There was no difference with versus without the patient targeted reports.
Isn't that interesting? How do you explain that one?
Well, I think to explain it, we really need to be chatting with the pharmacists and understanding. So what our effort really is now is doing interviews and surveys of the pharmacists to understand why that didn't work, what aspects worked and what didn't. We have hypotheses. I think part of it is that these pharmacists are busy. They're providing hypertension care, they're providing diabetes care, and maybe they don't have a lot of time to review these reports and pull new patients into their clinic. We've also found that maybe there might be better strategies of kind of increasing referrals for heart failure. Maybe it has to be more kind of directing those referrals from cardiology or from primary care rather than relying on the pharmacist to reach out independently.
You think your primary cares have bought into the concept of having the pharmacists work with them?
I think
specifically for this disease.
Our primary care colleagues in the VA really love the relationship they have with pharmacy, and so I think there's a lot of buy-in of working together closely for disease management. I do think that there's some site-level variability in the overall buy-in, both on the primary care and the cardiology side. We see some sites where we see a very large impact of the intervention and other sites where we see less. So I think we really need to understand.
You need to get in there and find out why those differences.
Exactly. I think those contextual differences are critical here, and it's kind of the core of implementation science.
Maybe primary care. Maybe that's where the issue is. Because not every primary care is the same, obviously.
Yeah, I think that's what we have to understand, and we have to learn from the sites that really took this on and try to see how we can translate those findings to the other sites.
I'm very curious that you were actually able to do some of this remotely. I have a very hard time doing telehealth. I can't see people's neck veins and do a good exam by telehealth. Was there any drug that kind of stood out as having done better because of the pharmacist?
Yeah. We saw up titration of all 4 classes in both arms. The only therapy where we saw a difference between the education only and the audit and feedback arms was MRA initiation or up titration. About 11% of patients that were on suboptimal doses of MRA or not on an MRA were up titrated in the audit and feedback arms, compared to about 9% in the education only arms. So that's the one significant difference we saw.
I mean, every time we look at these big databases, the MRAs really run at the bottom of the drug list, because everybody's afraid of the potassium. And if they get called at 9 o'clock with a high potassium, now they're going to have to do something about it. You guys have the potassium binders at the VA now.
We do.
5 years ago you didn't, but now you do.
Yeah, we do, and you're entirely right. Not only in this study, in our kind of pre-intervention data, MRAs are already lower than SGLT2 inhibitors. They've already exceeded where MRAs are. But when we've done a lot of work looking at medical therapy rates in the VA historically, and MRA rates have been flat, and they've been relatively flat for over 10 years now, despite being generic.
I think because you look at Spiro and you say, when I give this drug, am I going to see any difference in symptoms? When you give a RAS blocker, the patients are going to feel better. They'll feel better in a few days. When you give a Spiro, you don't see it, unless you use it as a diuretic.
Yeah.
Then you would see it.
I agree. I also think the historical sequencing of therapies has led to some amount of the inertia with MRAs, where patients get started on their beta blocker and RAS inhibitor, and the MRA is thought to be next, but we often just unfortunately don't get to that next.
I start the Spiro right away. I mean, you have to have really bad kidneys for me not to start the Spiro.
Yeah, I totally agree. I mean, there's obvious great mortality benefit. The hemodynamic tolerability is wonderful, and I think it's really critical that we solve this, especially now that we have data for non-steroidal MRAs and those with mildly reduced and preserved
And what are we
EF.
going to do with that one?
We got to figure out how to disseminate this opportunity to all of our patients.
So what's your next wave of things you're going to do?
Well, I think you hit on it, is that we need to figure out what worked and what didn't work. And so we're really diving into the qualitative data to figure out how to adapt our intervention. Once we've adapted our intervention, we're planning to test it as part of the AHA's Rural Health Equity Research Network across 3 additional VA regions. So we're really excited to both adapt, scale, and learn more about how we can scale the right way.
And then hopefully the VA data could be, used in the outpatient of people like us or the universities, not necessarily within the VA system.
Yeah, I think
it's not being done.
I think it's an important point. We have a unique position in the VA where we already have the pharmacists embedded in primary care. In some ways, it does, I think, limit the generalizability of these findings. That said, I think we all realize, even outside of VAs, we need these bigger team-based care approaches, and I hope that there's more and more and innovation around developing these, and the VA can be an example for other health systems.
When you look at data, take a look at how many minutes the pharmacists spend with each patient. Because I find that the teaching takes a long time, but when the pharmacists are with me, then that gets cut up. I do some of the teaching and they do some of the teaching.
I think that's a great point. I think something that we also need to look into is maybe GDMT rates didn't go up that much, but maybe that's partly because the pharmacist off-shifted some of the work from primary care and cardiology, and with the physician shortages we have, access is a really important outcome.
Well, I think you have a tremendous amount of good data here. I congratulate you, and Paul as well, for good work always done out of the Palo Alto VA. I want to thank my audience for joining me today. I am hoping that this will open up a new era and area of thinking. What a wonderful addition to your team to have a pharmacist. I love them. I've worked very hard to get them on my team, and I finally succeeded. Thank you for joining me. Have a great day.